This meeting is being recorded.
Hello and welcome to this short video on assessment and treatment tips when taking a biotensegrity focused approach to treating prolapse. This video is for physios who work with women experiencing prolapse. If you haven't already watched one of my videos explaining the reasoning behind this approach, please do so, either the short video seminar or any of the talks available on YouTube. Just to recap, here are the key points. Biotensegrity is a new and exciting way of understanding the body. It's not the system of mechanics most of us were taught at university, but it is now established as the best available framework for looking at human structure and function. The idea that organs can fall into the vagina due to weakness just cannot be correct. It is based on a model which is now out of date. Therefore, it is now time to question the clinical basis for using pelvic floor strength training as the main treatment for prolapse. By fitting our understanding of prolapse within a modern biotensegrity framework, we get a whole new, more optimistic way forward. A way forward which focuses on finding and releasing tension and stiffness within the abdomen and pelvis. We do not yet have a clinical trial to support this approach, but the early case data is strong. Essentially, I believe that we need to approach prolapse with a focus on finding and reducing excessive pelvic tissue tension and stiffness. We won't be able to find this stiffness if all we assess is contract, relax of the pelvic floor. It is only when we cross-match those findings with postural and movement assessment and thorough palpation that we can determine if the lack of pelvic muscle contraction that we see is due to stiffness or weakness. And it is important to ascertain this. For the participants in our recent research paper, pelvic floor power improved by an average of 2 grades through focusing on release work rather than pelvic floor muscle training. And 2 grades is a lot. That's because for those women, the tissue wasn't weak, it was stuck down. So my physical assessments always start with observations of the patient's posture, gait, and movement. The body is a 3-dimensional structure and the pelvic floor is a fully integrated part of that. So there are signs in the way that we hold and move our bodies which give us clues to what is happening inside the pelvis. So along with looking at things such as breathing patterns and diastasis, my postural assessment always includes, firstly, standing. What's their standing posture like? I will very often ask them to roll up their top and tuck it in here. And a lot of the time I'm looking to see if there's one foot stuck in an externally rotated position. That stuckness into an externally rotated position is an indicator that we've got some stiffness and stuckness going on there. Second, I always ask for walking. So without shoes on, I always ask for walking up and down. So things I'd be looking for would be, again, any signs of pulling or stiffness happening here, or even a reduced swing phase on one side. It might be that one side has a reduced swing phase, which again indicates some sort of restriction and pulling happening through there. Okay. I always ask for a single leg stand and I always ask for it twice. Okay, let me just make sure you can see me. So the 2 things that I'm looking, I ask for it twice on each side. So first, I'm looking to see how quick and automatic the balance onto one side is. So what's the balance like? Okay, and what's the balance like? So I'm looking on this side, what's the balance like? And on this side, what's the balance like? And then I ask them to do it again, but this time I'm looking at the opposite leg. So now I'm looking at what's the hip dissociation out of the pelvis like? So now standing onto this leg, looking here, what's the hip dissociation like? Is it good? Is it clean? Is it easy? Or is there like a bit of cheating? Okay, standing onto this side, what's the hip dissociation like? Is it good and easy, or is there a bit of cheating? Okay, so next I ask for a squat. So I'll ask them to face me side on, get a good view of the bottom and squatting down. So here, what I'm looking at is actually the roundness of the bottom. If the shape is nice and even and round, then that's good. But if there's a straight bit, if there's a bit that doesn't seem to give into that curve in the same way, then that indicates a stiffness or a stuckness correlating in there. So I'd ask them to do it on one side a couple of times, and then turning around, and then nice good view of the bottom, and again. Okay. So moving on to the couch, let me just twizzle you around slightly. Well, as well as your diastasis checks and things like that, the other things that I always ask for, or will do as a passive movement for them, is a passive abduction. I'll take hold of the ankle and move it into abduction, and a passive medial hip rotation. So I will move their leg up into this position and then medially rotate it. Okay. So the reasons why I look at those are that abduction can really indicate if there is a pull or restriction coming up this angle. And the medial rotation, I think, is really important for understanding a stiffness at the back of the pelvic floor. If you can't passively move your patient's hip into a medial rotation, then we know that we have a stiffness and stuckness in the external rotators. Those external rotators lie back to back with the posterior pelvic floor. So if there's a restriction into passive medial hip rotation, then we have a stuckness through that tissue that correlates with the back of the pelvic floor. If then that's the side where we later assess a lack of contraction, then we have our movement assessment and that lack of medial rotation to inform us whether that's a stiffness or a laxity. Okay, so by the time you've completed your postural assessment, and that doesn't need to be your whole postural assessment, that's just the things that I would always include when looking at somebody who's coming in with prolapse symptoms, then you should have a rough idea of which side of the pelvis is more dysfunctional. You might have picked that up through any number of those movements. Moving on to the vaginal assessment. Assessment should always include plenty of palpation of the whole structure. Particular focus should be given to the right and left sides of the posterior wall, comparing differences between them. My top tip with internal palpation is to use 2 fingers slightly flexed. Let me show you. So I'm going 2 fingers slightly flexed, bed down a bit, in that sort of a position. Okay. Movements such as squatting or raising a leg require lengthening of the pelvic floor. Okay, so if we are only assessing contract relax, we are only looking at the most inner range. So if we're only looking at contract relax of the pelvic floor, we're only looking at inner range. Without palpating deep into the tissue, we have no idea what's happening in that mid to outer range. That mid to outer range, which we need to use for simple movements such as squatting. So I would recommend asking the patient to take position on the couch with their knees pointing up and feet flat on the couch rather than knees pointing out. It's more comfortable for the patient and easier to get more palpation into the back of the tissue. So this kind of a position rather than this kind of a position. Most of the muscle bulk of the pelvic floor lies at the back, the 5 o'clock and the 7 o'clock regions. And this is also where most birth scars reside. So it's a key area to thoroughly examine. Take your time, go slow, be thorough. For puborectalis, you may need to be all the way up and over your hand, and for the perineum, you may need to be sitting. I'll show you. So for puborectalis, you may need to be all the way up and over in this kind of a position to be able to feel into it. And for the perineum, this is sometimes a good position. Fingers slightly flexed, resting on the perineum, leaning up and in. Stretchiness of the vaginal tissue should be symmetrical. How far does your finger sink into the tissue on the left and on the right? And how much space is there on each side? The side with less space is likely to be the side where most of the pulling is happening. An assessment of the superficial structures is really important. Stuck and stiff tissue in the superficial parts of the pelvic floor will cause a pull deeper into the pelvis. Beth Shelley's 2021 online course, Better Outcomes Through Accurate Pelvic Floor Muscle Assessment, explains how we should be recording our observations of tone of the pelvic floor and is based on the new International Continence Society report on terminology for pelvic floor muscle assessment. It's a really useful course. I recommend you check it out. So how do we integrate this into our treatment planning? So step 1 is teaching relaxation and softening of the abdomen and pelvis. This includes looking at breathing pattern dysfunction and addressing anxiety or gripping patterns. We can then build on this by adding skilled external or internal manual therapy, movement therapy, which focuses on opening, softening and aligning the pelvis, or any other techniques which act to mobilize the pelvic tissue. It's also important, of course, to look at any other musculoskeletal or movement issues in the rest of the body which could be feeding into the problem. Please note, I do not do internal release work for patients who have had major pelvic surgery in the past. This is because if any prolapse repairs or a hysterectomy has taken place, it's not going to be possible to restore their normal biotensegral arrangement, and I am super cautious about the possibility of disrupting any surgical fixations. So please take that same caution yourself. When using internal manual therapy, treating the superficial tissues is really important. Most of the time, the area of stiffness causing the pull through the pelvis will lie in the superficial layers of the tissue, including the perineum itself. For many patients, teaching self-massage to mobilize stuck tissue is really important. Again, focusing on the superficial layers is key, which can be done easily with their thumb. I have a separate YouTube video explaining how to do this massage. As pelvic physios, we can help by using our palpation to guide our patients to where exactly they are stuck and stiff and how that relates to their problems. Thank you very much for listening. I hope this little video has been useful. Bye.